to Kind Hearts, Strong Souls podcast, where reality and courage take the mic and hope leads the way.
The conversation of three friends united by work and held together by mutual care and support. Join Jodi as she moves through the challenges of a cancer diagnosis. The conversation is frank and honest, while also being caring and supportive. The voices explore the real pain and fear of cancer, the strength of faith and friendship and hope and optimism that shines even in life's darkest hours. Whether you're a survivor, a supporter, or simply someone in need of inspiration, this conversation will remind you that even when the road is very hard, hope is harder to break.
Good morning, everybody, and welcome to episode 6 of our podcast. We hope you all had a wonderful New Year's. I sure did. I did nothing, which is exactly what I wanted to do.
Good girl.
Yeah. So we're excited today to have our first guest, and he will be talking to you about some of the surgeries I've had in the past. Just to recap what I've gone through. I've had 2 major surgeries. One was in May of 2021, where 50% of my stomach was removed. I lost my spleen, part of my right diaphragm. I'm not really sure of the percentage of that. I think it was like 20 to 30%, but we'll figure that out. I also had surgery in September of 2021, where they removed 40% of my liver, my gallbladder, because it was in the way. And they had to scrape off cancer cells from my left diaphragm. So those were the major surgeries that I've gone through. I did, after the September surgery, had an internal bleed in October of 2021. We had to kind of sort through, figure out what that was from. And I've had a hernia repair just recently in November. And so, having said all that, in my last episode, I talked about Stephen being my Captain America and how he had a big part in helping me recover through all these surgeries. And I'd like to introduce the person who actually saved my life and is my hero, my actual hero. And he won't agree to that, but I'll die on that mountain all day, every day.
Nice. Superhero.
Yeah. Superhero number 3 in my life. I've always said I've been unfortunate, but I think back now after I talk on these podcasts, and I realize that I really haven't been unfortunate. I have Stephen in my life, who is amazing, as we all know. I have my medical team, who is amazing, all of them, from Dana-Farber to UVM. And I've just been lucky to get this whole great team of people. And so I might have to flip that script a little bit and start saying I'm starting to get lucky, and maybe I will start buying a Megabucks ticket. So anyway, without further ado, I'd love to welcome our first guest, Dr. Conor O'Neill. Dr. O'Neill is a surgical oncologist at UVM. He is the surgeon that has done all of my surgeries and will do any forthcoming surgeries. I've nailed his feet to the floor on that, and so we're good. So Dr. O'Neill, welcome to our podcast.
Thank you so much for having me. It's really been a pleasure to be here.
We're super excited. Can you introduce yourself and just tell us a little bit about your background?
Sure. I'm a surgical oncologist. It's a little bit of a long road. So I did I went to college here in Vermont, but I did medical school back home in Texas, where I'm from. I met my wife, and she wanted to be here in Vermont. So we've done most of our training back up here ever since. So I did residency training here in Vermont. I did a surgical oncology fellowship for a couple of years in Kentucky and a liver and pancreas fellowship there as well. And then after that training, we moved here to Vermont in 2020, where I now have a general surgical oncology practice and a liver pancreas practice. So it's been a lovely place to be here.
Well, shout out to Aaron for dragging him back to
Yay.
Vermont. Thank you so very much.
UVM Medical is lucky to have you,
Yes.
Dr. O'Neill.
Thank you.
Yes.
We have so many questions for you. We're so happy to have you with us and to be our superhero in Jodi's life. And one of my questions is, how is it that Jodi became a patient of yours?
Right.
Yeah, I want to know that as well.
Yeah.
Because if you started here in 2020, I was diagnosed in October 2020. So
That's right.
I might maybe have been one of your first-ish patients.
You
Maybe?
were. You were.
I was your first patient?
Not my first,
Oh,
but one of.
Okay,
You were-
okay.
You were early in this process.
Yeah.
Right. So Vermont as a medical enterprise has been around. They're one of the nation's oldest. But this is a small rural state. And when I was recruited here, it was one of their first ventures into having a dedicated GI surgical cancer practice. And so I came here with that intention. I think I started Labor Day weekend.
Oh my God, I was.
You were like just a month later.
You were only like a month and so in.
And so back, prior to that, my starting, I hadn't met Jodi yet when she was diagnosed. Most of those patients at the time stayed on systemic therapy indefinitely. And I do remember the tumor board where her case was discussed. And I was new, but I said, oh, well, she has treatable disease. I should meet her. And that's how that started.
Wow.
So you handpicked me.
I guess so. I handpicked your CT scan on the wall.
That's great. I love that.
Wow.
I never knew that.
That's
Yeah.
pretty neat.
That is pretty neat. Well,
Yeah.
thank you for picking me and
Well,
and taking
It's a-
on that challenge.
It's a match
Yeah.
made in heaven, honestly. I
That's
think.
right.
Yeah.
Yeah.
yeah, so it was kind of fun for me to review her chart a little bit before this podcast and remember the symptoms she was having back then and the reason for her seeing me, which at the time, if you remember,
COVID, right? She thought
it was
maybe.
COVID.
Yeah.
She was really sick to her stomach a lot and was throwing up a green color. And so they were worried about some blockage in her intestine, and we worked through that, had those conversations, and she was responding so well to her Gleevec, which I'm sure she's going to talk about a lot because she's been on this for a long time now. But she was responding so well that we knew that we had an opportunity to try to eradicate all of her disease.
Love it.
Dr. O'Neill, what percentage of your patients are GIST patients? That was a term that was new to us from Jodi.
Well, it's not a new entity, but we're understanding it more and more. They get grouped into what's called mesenchymal tumors or sarcomas. So gastrointestinal stromal tumors, or these sarcomas of the GI tract. I would say about 10 to 15% of my patients have they're considered rare, but I have a referral practice, so I'm biased. When patients have this disease, they're sent to me here. And so my percentage is probably higher than what you would see in a normal practice in the community.
So are you a GIST specialist?
I am.
Okay, good. I didn't know that.
I guess I am. We don't have a society necessarily that denotes that, but we do know that patients who are treated by people who specialize in this kind of care have better outcomes. And so we consolidate those treatments. There's only a few medical providers who do this, and I think only one or two in the state who do this for the surgical components.
Oh,
Wow. Awesome. I wonder, since we're getting into the details, if we could be reminded of the size and weight of the tumors and the locations, because it would be interesting to understand what they were in October 2020 and then for in May of 2021 for the second surgery, if that's possible to do.
Yeah, of course.
Yeah. Go ahead.
So I looked at her original, by the time I met her, she had already had some treatment and it had already shrunk in size. But on her very first CT scan, let's see when that was. Here we go. October 10th. At that point, she had a 21 centimeter by 17 centimeters. So about 9 inches by 7 inches. You imagine on this small woman,
Tiny
how large that
body.
is.
Yeah.
In her left upper quadrant. So this was behind her stomach or part of her stomach, pushing forward and backwards. And then she had another 7 by 7 centimeter metastasis that filled most of her right liver. So that's what we were starting with. And it looked at the time like it was invading pancreas and spleen and the diaphragm, the big muscle that separates the lungs from the abdominal cavity. So that's what we were starting with, 21 by 17. She had pretty favorable response over the next few months, such that by April, it went down to about 8.6 centimeters. So from that 21, so that's, an incredible response. But
so that was so encouraging for you to see and everyone to see she was responding to the treatments, right?
Absolutely.
Yeah.
That's
That
what
sometimes
provides
it
the hope.
doesn't happen that way. Yeah.
No, it can be resistant. And the reason
Right.
why we're all here in these conversations is due to the fact that there are some outstanding physicians and drug developers who were able to recognize these mutations and take advantage of them. And that's really what got her to the place where then they could even be safely removed. So she did this, and it wasn't easy. She had a lot of side effects for those treatments.
Right, exactly.
I still struggle, honestly.
And you're still on that medicine.
Yes,
I'm still
she
on
is.
Because it works, and
It does work, but it also has its unintended side effects.
Yes.
But yeah, so it shrank so much, but the rate of growth stopped. It was
Mhm.
shrinking so fast, but then it started shrinking still, but not as quickly as before. So we knew that this was our opportunity to strike while we knew it was still sensitive before it developed resistance.
Right. Wow. And it still hasn't developed resistance.
Or it's gone and it will never come back, but we'll never know that. So we know that by providing the pill, so long as she can take it, gives us the best opportunity to prevent a relapse.
Yeah.
So in any case, with this decreasing rate of shrink, I guess is the best way to say it, we elected to proceed. Now, because she was so uncomfortable in her left upper quadrant, she was having trouble eating at the time, she couldn't eat a full meal, we elected to start with that part. At least that would provide her with some symptomatic relief. And then if she recovered well enough, we'd go tackle the metastasis. It was too much surgery to do both of those in one setting.
Yeah, I remember you told me I would be mad at you if you did that.
Yes, and you would have been.
Yeah.
I stand by that.
Yeah, yeah.
When you think of the...
I have
go
a
ahead,
quick
Jodi.
question. Dr. O'Neill, in your medical opinion now, today, based on the tumors I had and the high risk of recurrence and all of that, if I were to stop taking my chemo, would they come back, do you think?
Oh boy, Jodi, difficult question. I don't know. We know that in some tumor types, we can do tumor DNA studies, so we can extract your blood and test for markers of circulating tumor DNA. And that may provide us some evidence to whether or not you're ever at risk for relapse. That just hasn't been validated in your cancer type. You are at a high risk of relapse.
Yes.
And so they see somebody who's young and fit and healthy, and they go, well,
Thank you.
That's our girl.
risk benefit ratio, we know that there are side effects and they're difficult to handle in the long range. As long as you're remaining disease free, it's probably beneficial to continue. We do know that continuing Gleevec for at least 3 years after tumor removal provides the best chance of long-term survival. That started off as a 1-year study, and we knew that taking Gleevec for 1 year was more beneficial. And then patients would have recurrences 2 to 3 years out. So they said, well, we'll take it for 3 years. And now we know that probably it should be 5 years. And now we're saying, well, maybe it is. It's just in your bloodstream waiting to grow, and we're keeping it knocked down, and you should just be on it for life. We will never be able to prove this unless the side effects become too morbid for you to continue and you need to stop.
Or it resists, right?
And then you stop that, and then it pops up either resistant or comes up as a result of your discontinuing the Gleevec. If you were to stop it and it never came back, then it probably was never going to come back. It's just a difficult gamble to take.
I'm finding all this very fascinating. Dr. O'Neill, at like 10,000 feet, very high level, can you just walk us through a little bit of what GIST is to a layman, and how your understanding of it has evolved even in the last 10 or 20 years?
Okay. I think layman's terms, most cancers arise from the skin layer of your body. So they arise, melanomas come from your skin or the lining of your GI tract. So your mouth, esophagus cancer, these are all considered the endothelium or the ectoderm, endoectoderm, from your primitive development as an embryo. There's a second set of solid cancers that arise from the mesenchymal layer, and that layer is your connective tissue, your muscles, bones, nerves, and arteries. What a GIST tumor is a cancer that arises from the muscle wall of the GI tract. So most colon cancers arise from the skin layer. This arises from the muscle layer, which also means that there's no real environmental factors that can precipitate its growth that we know of. It's not like somebody smoked too much or they had too much red meat or whatever these population level associations we try to derive from cancer. These mesenchymal tumors, we don't have a lot of evidence to say that there are environmental contributions to its development. So that's been one classification, is in our understanding of the histology from which it arrives, that we've known for at least 20 years. But in those last 20 years, it's been a much better molecular characterization of these tumors, such that we can exploit some of the mutations in these cancers to provide effective treatments. And one of those, most clearly in GIST, is development of Gleevec or imatinib. So that's been our biggest understanding, is how we can, there are other mutations and she doesn't have them. And sometimes there are different drugs that work well that I think is unnecessary to talk about, but she has the standard and she's been very responsive to it.
I think one of the things that fascinates, maybe fascinate is the wrong term, but causes questions in our head when we hear about Jodi's story is that her cancer came on in a very non-obvious way. She didn't go to the doctor and say, hey, I think I have something growing in my insides or something like that. She went to the doctor because she went to the ER because what she thought was the side effects of the flu. So what are the most common symptoms that lead to patients to seek GIST care? Is there some pattern of early warning that people could look for?
No.
Hmm.
Most patients are asymptomatic.
Mhm.
Again, and it arises from the muscle layer, so
Mhm.
it tends to not necessarily cause symptoms.
Mm-hmm.
So the symptoms that do arise are when they're so large they cause mass effect and side effects from them, large mass pushing on adjacent structures.
Hmm.
Or in these earlier stages, this muscular tumor erodes through the skin lining of the GI tract and it causes bleeding.
Mm-hmm.
So sometimes patients will present with blood in their GI tract, whether in their bowel movements or they've had an episode where they've thrown up and there's been blood. And those, or they have anemia on labs when they're going to the doctor for a routine checkup. Those are the most common ways we identify those in an early setting, because there are not a lot of symptoms that drive this.
Hmm.
When I went to the Life Raft group conference, Ken, I remember them saying that, I want to say it was a high percentage, like 70 or 80% of the GIST patients were diagnosed incidentally. They went in for something else, a
Mm-hmm.
CAT scan of their lung or something, and it happened to show up.
Mm-hmm.
So it sounds to me like it's incidental, like,
It is.
yeah.
I mean,
Yeah, it really does.
The
Which
best
is
way is
pretty
again,
sobering if you're just a person going through life, right? So
Hello.
yeah,
Yes, it is
Yeah.
sobering.
yeah.
but at the same time, it can also be reassuring. The people who do well are those who are in tune with themselves and their body.
Mm-hmm.
You know, there's no particular screening, there's nothing you can be aware of, but people who are aware of how they feel and how they're doing, that's the best you can do.
Mm. You're fascinating me, but you're also like making me go like, really?
Yeah.
Um,
I'll have him fascinate you a little bit more, Dr. O'Neill. Can you tell us, because I've always wanted to know this, which of my surgeries was your more challenging surgery and why?
Okay. Your last one was easy. That was great. I
Really?
love that one. The hernia repair. Yeah.
Oh, see, I told Ken and Brenda when we were talking about questions that
So
I would have picked the second surgery.
okay,
Because of the
so
liver.
of the three, because now we've done three.
Yes.
The
of the three.
first, so the first one was the removal of the primary tumor,
Yes.
and that one was a little bit more challenging because you had so much response to treatment that the tumor turns into kind of a jelly ooze. But you don't know if it's fully dead or not. So you can't risk getting into that jelly. You need to make sure that you can have an on-block resection. So I wound up taking probably a little, well, definitely, because most of it was dead. I wound up taking more than I needed to, not of your stomach, because that's what it was growing off of, but it was touching your diaphragm. So I just took, I took credit card size, I guess. I'm looking at this thing right here.
30%-ish.
Yeah, I mean, you're
It's
so small.
20,
Yeah, you're
yeah.
so small. It seemed like a small amount of diaphragm, but she's a small woman, so you're right.
Yeah.
That's it was a lot of diaphragm. In any event, it's dying, and so it isn't a firm mass that you can move and manipulate. You have to make sure that you don't rupture this dying tumor, and so that was technically challenging to ensure that we had an on-block margin negative resection. Your second operation, and I knew that that would be hard to recover from. Now you have a smaller stomach, your second operation was a higher risk operation for perioperative challenges. It was 2 or 3 months later, doing a right hepatectomy with your prior scarring. And removing the liver does runs a high risk of bleeding. And so those they're usually safe, but can have catastrophic bleeding associated with it. Fortunately, you didn't, and we had a nice, safe, good operation. That one was challenging just because of the scarring from your prior operation. I remember thinking at the time, whoa, this is hard.
Yeah.
But it went fine in the end. And again, she had such a beautiful response. But we did because of the location, we had to remove her whole right lobe of her liver. But she's so healthy. She responded from that beautifully.
Well, I don't know about beautifully.
Well,
That was a tough one.
From a liver surgeon perspective.
Yeah, from your
It
perspective.
grew back.
Yeah.
Beautiful liver.
Yeah.
Beautiful liver.
Yeah.
Yeah, that's right. And then, years down the road, she does develop a small hernia from her three prior incisions. Because you had that prior surgery years and years and years ago.
Yes, that's right.
But that one, fortunately, was nice and quick.
Yes.
It was just around the time of her grandson. So we wanted to get her back to action with her grandson quickly.
Yeah.
Right.
Yeah. And that one, as I understand it, was a little tricky for him, from what I understand him. I don't want to speak for Dr. O'Neill, but I guess he had to remove my belly button out of the way to get into the. Yeah. He could tell you that. But
Well, maybe she does maybe we made her belly button cute. Who knows?
No, we
But
didn't.
It was a periumbilical. It was a belly button hernia. So we
Yeah.
have to lift the belly button out of the way and then fix the hole and put the belly button back. And
Yeah.
you just hope that you tack it back where it used to be.
We talk about the evolution of the belly button over all these surgeries. I'm about ready to have him just close it up.
Yeah.
I think I asked a question about this when the three of us were talking and I got in trouble. So I'm not going to go down that rabbit hole at all. But anyway, hey, Dr. O'Neill, what advice would you give to somebody that's just newly diagnosed? We hear about advocating for ourselves in these times and that sort of thing. What would you say to somebody like Jodi that was just starting their journey?
I think number one is to take a deep breath. It can feel so overwhelming. The world is spinning and you feel like you've really lost a lot of control. There are so many options. The sky is not falling yet. It's important that you collect opinions, not from just your local doctor, but from higher volume doctors as well, who see a lot of this. And you evaluate your options that seem to best fit with your goals. Everybody is on a different path. Everyone has a different journey. And it's important that your medical care rise to your goals and your journey. And you don't have to fit into that box. That's the best advice I can give, is to take a deep breath, get your information, and make a plan from there.
Yeah, that's great advice. I'm really curious about how you work with the other team of people. My mom went through ovarian cancer and lived on 2 parts of the United States, and we had a team in the Mayo Clinic, but also her UVM oncologist. And I just wonder if you could give us a visual of how you work with Jodi's teams at Dana-Farber and also the oncologist she has at UVM.
Yeah. So we've developed, and not just UVM, but most academic medical centers have really robust multidisciplinary teams, or these MDCs, where for us, we meet Monday morning at 7:30, and every Monday, we discuss the new patients or ongoing patients, and we have questions or concerns that we ask the whole group. And the group is not just surgeons, it includes medical oncologists, radiation oncologists, the radiologists who read the scans, the pathologist. And we try to discuss best plan of care or issues that are arising in the care or advice regarding treatment for it. You know, the patient doesn't like Gleevec anymore. I was thinking about this. What do you guys think? And we make that a private meeting specifically so that we can really speak frankly.
Yeah. Brainstorm and yeah.
Yes,
like-
without any risk of looking foolish in front of the
Mhm,
patient, for
mhm,
instance.
mhm.
We need our own human protections sometimes to just say, whoa, this is hard, guys. What do you think I should do? And we meet every Monday. So her oncologist, I see not only at least every Monday, I also know her very closely, and we hold clinic on the same time on Wednesdays.
Mhm.
So we pass each other in the hall. I'm like, hey, I just saw Jodi. What do you think? I'm thinking this. And so we have an on-the-fly discussion, I mean, twice a week. That's been very helpful in moving care of cancer patients across the US, but really here in Vermont. This is a small state, and I think we are robust, but there's only 600,000 people here. I'm not going to have 10 different surgical oncologists that I work with. And, you know, we try to, for our motto, a long time, our motto has been, you know, big medicine in a small city. And they do try that. But it also allows us to collaborate outside. And so our oncologist here knew that she should also have an opinion at a larger center where that person is really just doing just tumors, not just GI cancers altogether, but specifically just. And those opinions help not only our medical oncologists feel confident about their decisions, but help the patients who get these opinions say, all right, great, I can continue to get my care here at home, because even when I drive to Boston, they're going to do we're doing the same things. And it helps us get that advice and help patients keep their care and not need to drive 4 hours every few weeks.
Very good. You know, it also occurs to me you guys have such a good relationship, and it, like we said earlier, kind of a miracle putting you two together. Are you tied to Jodi, especially like with, I even picture, what if she goes to Savannah, Georgia, and something happens? Do you get an alert if she's at a hospital somewhere else, type of thing? Is there a network like that going on for
Yes, I do. If she does anything in the state of Vermont, I get an alert.
We're keeping her confined?
Or in Boston.
Okay.
Or in Boston. The hospitals have to have agreements in place for data sharing.
Okay.
And so we do with our region. Now we're all, you know, she can see our chart up, her chart is up right here. And we use a company called Epic for our charts. And most hospitals use Epic, so I can get access, but I don't get routinely notified if they're out of our network.
Gotcha. Interesting.
But there are some that you keep closer tabs on than others.
I bet. She would be
I think that would be
top
me.
of the list.
I'm not
That
sure.
would be you.
I'm not sure though, but
Yeah.
I will have to say, you know, both times when I was in the hospital for both of my big surgeries in May and then in September, Dr. O'Neill came to visit me in his street clothes. He wasn't even working. In fact, I remember when he came in May, he walked in the room and Stephen looked at me and I looked at him. We're like looking at each other like, do you know this guy? Because we only saw him with his surgical hat, everything. And literally we saw his eyeballs, was all we ever saw of Dr. O'Neill.
Right.
And so we never even knew really what he looked like.
Yeah.
And then he introduced himself and we're like, oh. And then we're like, oh, what are you doing here? And so he came off the street to see how I was doing for both of my surgeries, and also checked in when I had the internal bleed wanting to make sure it was nothing on his side that was, this, because I just had that surgery in September.
Right.
And then I have this bleed in November. And, he wanted to make sure everybody was doing the right thing for me.
Yeah.
And so he was monitoring that as well.
Yeah.
So
Jodi, you reminded me of one of
part-
the,
I think there's a humanist part about all of it, but really doctors come in all shapes and sizes too. But I think ultimately you really do form a connection with the people who entrust you to care for them. And and I think that there's an indelible link that's created from that doesn't end.
right.
Nice.
yeah.
Of the
Nice.
three of us, I'm the highest mileage. I think you can tell by looking. So one of the things you go through as you age is that your doctors begin to look more like your children's age.
It's true.
And I'm not quite there, but I've got a grandchild that's going to go off to university. And, it won't be that long before my doctors start looking like my grandchildren. So, it's
Well,
just what.
imagine 5 years ago when I met Dr. O'Neill, 5 years ago.
Yeah. 5 years
I
ago.
mean, looks young now. And I honestly thought he was my son, or I'm like, you really? You're going to operate?
Yeah. Do you ride a bicycle to work, Dr. No, I'm kidding. Anyway.
Not anymore.
We are very, very grateful. In our minds, you're doing the work that angels get to do. And it's a serious thing, but it's also a wonderful thing. We live in amazing times where God has allowed us to discover just fascinating things. And I think from a layman, I look at Jodi and I think to myself, if this had happened 25 or 30 years ago, there might not be any Jodi to speak to anymore. So we're very, very grateful for the work that you and others that do your kind of work do. You make a difference in families well beyond those that you treat. And so we thank you so much.
Yeah.
Thank you. It's, it goes both ways. It's a beautiful experience. It's a incredibly rewarding job. Sounds like such a wrong word for it, but it's and this is a small state. I don't just see Jodi in the hospital.
No.
And I don't see, it's increasingly not just patients who come, but it's a community of people that we all get to serve one another. And I think that has just an incredible value.
Yeah, absolutely. Absolutely.
I know I'm grateful that he's on my team, and will be for the foreseeable future. Like I said, I nailed his feet to the floor already. So
yeah.
He's kind of stuck with me.
Yeah, he doesn't seem to mind. I think there's a good simpatico there. So
yeah.
Well, Dr. O'Neill, if you've listened or if Jodi has told you, we normally close our podcast with a word of prayer. Do you mind if we do that and include our gratitude for you in that?
Of course.
Okay. Father in heaven, we're grateful for the place you take in our lives, that you guide us to people that can not only be community to us, but can build us up our spirit in terms of our spirit, or build us up in terms of our medical treatment, or build us up in terms of just being friends and family. And we thank you for the place that you've given Dr. O'Neill in Jodi's life. We thank you for the gifts and the talents that you've given him for treating others, and for the heart that wants to do that. And so we're very, very grateful for that. We ask that you would continue to be with us, be with the other patients that Dr. O'Neill has influence in the lives of, and be with us as Jodi's community of encouragers and those that try to uplift and just surround her with our care and our love. We thank you so much for your goodness in our lives. In Jesus' name, amen.
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 Hey, thanks so much. I don't know if you could tell by my face, but I was completely fascinated. I was like, give me more, give me more.
Yeah, we could have
So-
gone all day. Ken had a really long list of questions. He really wanted to ask. but
Yeah,
we
what I
had to
have, like
narrow it
9
down.
pages or something. I can't remember.
Yeah.
So
No, it should be
anyway,
exciting.
Yeah, yeah.
good.
Thank
Well,
you
thank
so
you.
much from our kind hearts to your strong souls. Thank you for listening. Thank you for joining us today. Your support helps us share hope, so please leave a rating, like, or subscribe to the podcast and share frequently. God bless you all.